The first words out of my mouth after an adjustment on a motorized flexion distraction table was, "That was an adjustment." I felt joints in my back move that have never moved before. After that adjustment, I knew I needed to purchase one of those tables and learn that technique. If that adjustment made me feel that good, I wanted my patients to feel that good. I hope to teach you the light force adjustment technique of motorized flexion distraction and motion adjusting. Since 1990, practitioners in the field have reported with great success in the treatment of spinal conditions using motorized flexion distraction. Flexion distraction can be used to increase the intervertebral disc height, allow the nucleus pulposus to assume its central position within the annulus, restore vertebral joints to their physiological relationships of motion, improve posture and motion while relieving pain and improving body function. Spinal conditions treated on a motorized flexion distraction table: sciatica, general back pain, scoliosis, Facet syndrome, spondylosis, degenerative joint disorders, spinal joint fixations, sacroiliac joint disorders, spondylolisthesis. Prior to admission of a patient for motorized flexion distraction, perform a thorough clinical examination and evaluate to determine if the patient can benefit from flexion distraction. Contraindications for the use of flexion distraction are acute inflammation, vascular diseases, acute disc fragmentation, sequestration or non-contained disc injuries as confirmed by CT or MRI, cancer, bone infection, osteoporosis, tubercular bone disease, recent fracture. Flexion distraction should be discontinued if a patient complains of dizziness, nausea, undue discomfort or pain, motor weakness, or increased numbness. Proper patient-to-table positioning is very important. Allow time to familiarize yourself with the table and all the movable parts. Always start with the table in a neutral or flat position. The handlebars positioned next to the face cushion. The ankle support cushion should be positioned next to the pelvic cushion. Position the patient so that the top of the iliac crest are even with the top edge of the pelvic cushion. Instruct the patient to grasp the handlebars. Pull back on the handlebars slowly until the patient's elbows are slightly flexed. Patients can exacerbate injured shoulders, elbows, or wrist if the handlebars are pulled out too fast or too far. When a shoulder, elbow, or wrist problem is present, instruct the patient to grasp the ends of the armrest. Grasp the abdominal section under the back edge with your right hand, and with the left hand, release the abdominal lock to lower the abdominal section. Slowly guide the abdominal section down until it stops. Do not lower this section fast. Abdominal weight will cause the section to drop too rapidly, causing lumbar sprain strain. Lowering the middle section allows for the lumbar spine to be in a normal lordosis for joint movement. Patients with large breast, intercostal neuritis, clavicle disorders, post-abdominal and chest surgeries, and barrel-chested individuals may have discomfort with the top edge of the abdominal drop. For better comfort, reposition the patient by moving the patient's iliac crest down 1 to 2 inches below the top edge of the caudal section. Never have these patients move up. Always have these patients move down on the table. Slowly lower the hinged cervical section approximately 25% from the neutral position to the floor. Pull back on the foot cushion to the top edge of the foot. After the patient has been properly positioned on the table, inform the patient that you are going to start the table in motion, causing the bottom section of the table to move. They may feel a stretching or pulling in the low back. Gently rock the patient's lumbar spine side to side. By rocking the lumbar spine, this warns the patient that the table will begin to move, eliminating any surprises. After the table has made one complete cycle motion, ask the patient if they are feeling any discomfort in the low back, hips, or legs. If the patient feels no discomfort, continue with the movement of the table. After the table has completed 5 or more cycles, the patient has adapted to motorized flexion distraction. It is normal for a patient to feel a pull or a tug in the low back muscles as the table descends. If the patient is feeling moderate or severe discomfort, stop the table, discontinue with flexion distraction. This procedure should be tested on every new patient or new injury. Some motorized flexion distraction tables are equipped with a variable speed control. A variable speed control allows the doctor to reduce the speed of the caudal section, making it easy for the patient to adapt to motion. After the patient is comfortable with full flexion distraction movement, ankle straps can be applied to increase long axis distraction. They are also helpful in stretching tight hamstring muscles, calf muscles, and gluteus muscles. Do not use the ankle straps with patients who have severe hip, knee, or ankle pain. Do not leave the table unattended with children in the room while the motor is running. Children could harm themselves under the pelvic section of the table. Have children seated at the front end of the table while in use. After you have familiarized yourself with the table and you're comfortable placing the patient properly, you are now ready to apply therapeutic motion-assisted stretches. The use of motorized flexion distraction allows the practitioner the hands-free ability to stretch joints and muscle while in motion. These stretches are usually applied prior to the adjustment by the doctor or trained assistant. Stand close to the table, elbows locked, use firm palm-hand contact. As the caudal section of the table descends, lean over the patient by rocking forward onto the balls of your feet. Use your body weight to provide stretching force rather than using your arm strength. When the caudal section of the table reaches the bottom, maintain a palm-hand contact and return to your heels. This rhythmic motion, back and forth, expends little energy while providing significant stretching force. Apply equal and gradual pressure with both hands. Pressure is applied only when the patient's feet have started in a downward motion. Decrease pressure when the patient's feet have started in an upward motion. Remember, this is a stretch, not a spinal adjustment. Be careful not to dig or thrust into the muscles or joints. Keep in mind the patient's comfort. Motion-assisted stretches are applied for approximately 1 to 2 minutes. This procedure provides a relaxing stretch to the muscles and incorporates intervertebral traction to the spinal joints. Notice any pain or discomfort expressed by the patient. Discontinue stretches if pain or discomfort persist. When stretching specific muscle groups, follow the direction of the muscle fibers with your fingers. These are the most commonly used stretches: sacrooccipital stretch or long axis stretch, sacrothoracic stretch, thoracolumbar rotary stretch. The sacrooccipital stretch is applied by placing the superior hand cupped at the base of the occiput. With the inferior hand, place the firm palm-hand contact on the sacral base with the fingers pointing down. As the table descends, keep the elbows straight, lean over the patient, and apply an even pressure to the occiput, pushing upward. At the same time, the inferior hand is holding the sacrum down. Release all pressure, but maintain a contact as the table returns to normal position. Repeat 6 to 7 times. The sacrothoracic stretch is applied by placing the inferior palm-hand contact on the sacral apex. The superior palm hand is on the upper thoracic spine, 2 inches outward, away from the spinous process. With elbows locked, apply equal and gradual pressure with both hands as the table descends. Move the superior hand down 1 or 2 spinal segments and apply pressure as the table descends. Work your way down one side of the spine, then the other. The thoracolumbar rotary stretch is applied by standing on the opposite side of the patient. Grasp the anterior ridge of the iliac crest with the inferior hand. With the superior hand, use a firm palm-hand contact along the erector spinae muscles, starting with the upper thoracic spine. As the caudal section of the table descends, simultaneously pull upward with the inferior hand and push down away from the spine with the superior hand. Decrease pressure when the caudal section ascends. Move the superior hand downward along the thoracic and lumbar spine. Repeat on the other side of the spine. With the spine in motion, the practitioner's hands are free to motion palpate spinal joint movement or non-movement, from the base of the skull to the sacrum. The practitioner can palpate long axis motion with one hand or both hands, and observe motion in the articular joints with lateral flexion. Changes in joint motion can easily be noted after spinal adjustments. After becoming comfortable with applying motion-assisted stretches, you are now ready for motion adjusting. Motion adjusting is applying your specific technique to a spinal joint in motion. Use the same angles and line of force used on a non-motion table. As the table flexes, this forces movement in the spinal joints. With the combination of joint movement and spinal thrust, the joint becomes hypermobile, Thus, a lighter force is required for corrective movement. Stand close to the table and lean over the patient. A spinal adjustment is only given as the table descends. This procedure is used when adjusting the upper thoracic to lower lumbar spine. Because the joint is in motion, apply less force or thrust. Never apply a corrective force when the table is moving upward to avoid jamming of the facet joints. Adjusting side posture on a straight bench table can be a struggle for the patient and for the practitioner. The patient either feels as if they are going to fall off the table, or the doctor struggles to keep the patient on the table. Lateral flexion of a flexion distraction table has several benefits for side posture adjusting. It's easy to motion palpate the lumbar spine. The patient is comfortable without feeling of falling off the table. Raise the hinged cervical section upward to full extension. Flex the patient's knee up to patient tolerance. Place the patient's iliac crest at the top edge of the pelvic section. Lower the abdominal section. This allows for more lateral flexion of the table. To motion palpate the lumbar spine, push and pull the upper section back and forth. After you have located your specific spinal segment to be corrected, pull the tabletop towards you as far as possible to open the lumbar facets. It is very important to lean over the patient, using your body weight, not arm strength, when applying corrective thrust or force. Notice how far the doctor is over the patient. When the patient relaxes and the lumbar spine flexed, apply your corrective adjustment. With a little practice, you will be adjusting your largest patients with ease. One of the most common spinal conditions seen in a chiropractor's office is acute low back pain associated with herniated or bulged disc. The following is an example of how to treat a patient with acute low back pain with a right lateral herniated disc on a motorized flexion distraction table. Have the patient lay on the table with the bulged disc side down to avoid further compression of the disc. When treating an L5 herniated disc, position the patient with the top of the sacrum even with the top edge of the pelvic cushion, leaving the L5 disc space free to move. If the patient had an L4 disc herniation, move the patient down so the top of the L5 vertebra is at the top edge of the table, leaving the L4 disc free to move. Bend the patient's knees up approximately 25% to decompress the L5 disc and facet joints. With the right hand, use a firm palm contact on the spinous of the L4 vertebra. Slowly flex the table towards you as far as possible and return the table to its neutral position. Do not exceed the neutral position to avoid further compression of the disc. Repeat 10 to 12 times. Stop if the patient feels any discomfort. Have the patient flex their knees another 25%. Slowly flex the tabletop back and forth 10 to 12 times. Again, stop if the patient feels any discomfort. This procedure decompresses the L5 disc, decreases facet joint stress, and increases joint motion. While the patient is in this side posture position, apply ice, appropriate therapeutic modalities, or light force adjusting techniques. Upon completion of therapy, have the patient slowly ascend from the table in a side position and apply bracing. Apply treatment twice daily or until the patient is standing straight and able to dismount the table without any sharp or jabbing pain. If you have a flexion distraction table with a variable height or uplift control, raise the top of the table as far as possible, keeping the pelvic section flexed down. When the table is in this position, it is easy for the patient to mount or dismount the table without aggravating the condition. When treating an L5 disc herniation, have the patient mount the table with the top of the sacrum at the top edge of the pelvic section. If this patient were to have an L4 disc herniation, position the patient so that the top of the L5 vertebra is at the top edge of the pelvic section. Adjust the variable speed control to slow. Use a firm palm contact on the L4 spinous and hold. Turn on the table. As the table descends, be careful not to push or thrust on the L4 spinous. After the table has made 8 to 10 complete movements, stop the table and apply ice, appropriate therapeutic modalities, or light force adjusting techniques. This procedure decompresses the disc, decreases facet joint stress, and increases joint motion. After the patient dismounts the table, apply bracing. Apply treatment twice daily or until the patient is standing straight and able to dismount the table without sharp or jabbing pain. Repeat as needed until the patient is asymptomatic. Motorized flexion distraction tables are multi-purpose treating tables that can be used for various adjustment techniques. Within a short time, you will learn to adapt your adjusting technique to motion adjusting. Soon your patients will say, "That was the best adjustment I've ever had."